Good morning. Thank you all for coming back in. And we're going to get started so we don't keep you from lunch too late. And what I am going to be talking to you about is really the nitty-gritty about how the Texas newborn screening functions, what we screen for, and what our processes are. So, as Dr. Kemper has alluded to, the basics about newborn screening is it's a program that screens in Texas right now for 30 congenital and heritable disorders. The disorders may cause severe intellectual disability, chronic illness, death, with no clinical symptoms detectable at the time of birth. Early detection and treatment leads to dramatic positive outcomes for most affected babies, and typically treatments through diet control, hormone replacement, and medical supervision. So, when do we do the screen? The timing is everything. Many disorders cause irreparable damage in the first days of life. Changes in diet and/or other simple interventions can sometimes prevent lifelong consequences. And if an abnormal newborn screen result occurs, prompt follow-up is critical. Accuracy in testing and correct demographic information are essential. So as of December 2012, Texas screens for 30 disorders. There were 29 rare disorders that are the newborn screening blood spot specimen that Dr. Kemper had alluded to, and we'll talk a little more about those. And congenital hearing loss is considered another newborn screen, and that's a point of contact screen. We have an advisory committee. The Newborn Screening Advisory Committee was only formed in 2010. It's a 9-member committee. There are 2 additional members that were added in 2014, and its purpose is to advise the Department of State Health Services on strategic planning, policy rules, and services related to newborn screening tests. So in Texas, the hearing screening is called TEDI for Texas Early Hearing Detection and Intervention, and it can be accomplished by one of 2 ways. One is otoacoustic emissions, and the second way is automated auditory brainstem response, or what we used to call the BEARS. The timing on this is that screening occurred before 1 month, 3 months for confirmation of diagnosis, and treatment before 6 months. In reality, we really want that treatment to start much sooner and the diagnosis to be confirmed so that child can be entered into services. And as Dr. Kemper had alluded to, with the newborn hearing screening, there is a large number of children that were said to be lost to follow-up after they have an abnormal screen. But as he alluded to, most of that we think is related to documentation, so it's really lost to data entry. Texas does have 2 grants that are working on to decrease the loss to follow-up rate. One's a HRSA grant and the other's a CDC grant. And both of those are looking at both interoperability to make it easier for the provider to report the results back to us, as well as trying to track and figure out causes of the loss to follow-up, or quote-unquote the loss to data.